Thank you so much. So once again, good evening, everyone. My name is Vipul Sanghvi, and I'm a DNB Nephrology Resident in TM Hospital, Pune. Thank you so much to ISN who gave me this opportunity to present this paper in today's forum. We're going to be discussing this BEST fluids study, which was a pragmatic, registry-based randomized controlled trial, which was done mainly in the Australia and the New Zealand between the year 2018 January till August 2020. This trial was then published this year in July 2023 in Lancet. The delayed graft function, which we define as the requirement of a dialysis within the first week of a transplantation, is most commonly seen in diseased donor kidney transplants, whereas its incidence is up to 20 to 30% in the patients who receive this diseased donor kidney transplant. Of course, it has its own consequences in terms of increased risk for acute rejections, worst 5 years graft survival, eventually leading to graft loss. Since we all know that the 0.9% normal saline has been the most commonly prescribed crystalloid worldwide, and this has been critically analyzed in critically ill patients, which has implicated in increased incidences of AKI. Having this understanding in mind, BEST fluid is a trial aimed to minimize this burden by choosing the right fluid around the time of transplant. So balanced crystalloid solutions are nothing but the low chloride crystalloids. Some of the examples are Ringer's lactate, Plasmolite 148, and Hartmann solution, etc. They have been studied as an alternative to normal saline in large randomized controlled trials. So these are few of the randomized controlled trials which actually studied balanced crystalloids versus normal saline in critically ill patients. Largely, when we look at their outcomes, it did not differ or did not show any benefit of using balanced crystalloids in terms of mortality benefit. But in the SALT AD trial and the SMART trial, which have been one of the largest clinical trials, showed the benefit in terms of major kidney outcomes at day 30 by using balanced crystalloids. So extrapolating this information, there was a Cochrane analysis done by Van S, who reviewed 6 RCTs and 5 studies where 477 participants were recruited, both living and the diseased donors, and they studied these outcomes. Clearly, use of balanced crystalloids was associated with the lesser incidences of hyperchloremic metabolic acidosis, as well as the incidence of hyperkalemia was less in that group, but the benefit in terms of delayed graft function was uncertain. Further updated meta-analysis included 3 more additional studies, but again, there was an uncertainty regarding the delayed graft function and the benefit of balanced crystalloids over it. All the trials were single center and small. At the same time, exclusively, there was no study which was which recruited only diseased donor kidney transplants, and as a result of which the BEST fluid study was undertaken. So the aim and objective of the study was whether the use of balanced crystalloid solution reduces the incidence of delayed graft function in diseased donor kidney transplant. So this was a pragmatic investigator-initiated registry-based trial. It was a double-blind randomized controlled trial, again multi-center involving 12 sites in Australia and 4 sites in New Zealand. The duration of the study was between 26 Jan 2018 and the last patient exited at 20 August 2020. So the population which were recruited were the adults and the pediatric patients weighing more than 20 kgs. Obviously, end-stage kidney disease patients who underwent diseased donor kidney transplants. The patients who required multi-organ transplantations or those who were weighing less than 20 kgs, as well as the patients who had hypersensitivity reactions to the trial fluids were excluded from this study. The intervention was the use of Plasmolite 148 versus normal saline. So the Plasmolite 148 used intraoperatively and postoperatively up to period of 48 hours. The control was use of normal saline 0.9%. The outcome was delayed graft function, which was clearly defined as the need of dialysis within the first 7 days of a transplant. So the randomization was taken place by using this method called adaptive minimization algorithm. The patients were randomly assigned into 1:1 between the intervention arm and the control arm. The intervention arm was the Plasmolite 148, whereas the control arm was the normal saline. This randomization was taken place by using centrally recognized electronic-based system accessed through this central registry. The minimization factors which were considered were transplant center, disease donor type, whether DBD or DCD, use of hypothermic machine perfusion, and kidney donor tertiary index. So in the current trial, participant, investigator, and even the analyst, all three were blinded. As you can see it in this image, these were the pre-packaged 1 liter fluids, which mentions only the best fluid, trial fluid, but does not say whether it is a 0.9% normal saline or a Plasmolite 148. So the fluids were masked by this. It had a patient label, and each bag was coded with the number for the analysis. So all the three participant investigators and analysts were blinded in this trial. The assigned fluids were given for a maintenance, replacement, and the resuscitation during and after the surgery until 48 hours of a transplantation or cessation of the intravenous fluid, whichever occurred earlier. It was at the clinician's discretion of the volume of the fluid and the rate of the fluid was decided by the treating clinician. This trial was funded by the Medical Research Future Fund and the National Health and Medical Research Council Australia, Health Research Council in the New Zealand, and the RACP Australia and the Baxter. So the data was collected for the following variables, including baseline demographics, clinical characteristics, trial fluid volumes, open label fluid use, urine volumes, body weight, data on the disease donor characteristics, acute rejections, episodes of acute rejection, graft function up to 52 weeks, graft and the patient survival, and serious adverse events up to day 7. So the primary outcome, as I mentioned, it was delayed graft function, which was the requirement of a dialysis within the first 7 days of a transplant. Patients who died and who also had an early graft failure were also included in this primary outcome. The secondary outcome has a long list, which with the important secondary outcomes were the rank composite outcome of delayed graft duration and the creatinine reduction on the day 2, the number of dialysis treatments up to day 28, and the duration of dialysis in terms of days up to 84 days or 12 weeks. Also, creatinine reduction 10% or more in the first 3 days. The total number of patients requiring treatments for hyperkalemia, peak potassium levels, fluid overload, aggregate fluid volume up to day 2, use of inotropes and vasopressors during and after surgery, the rejection episodes, mortality at 1 year and 5 years, and the graft survival. So these were few of the secondary outcomes which were analyzed during this trial. The statistical analysis, the primary outcome was analyzed using log binomial regression model with the fixed effect treatment group. In a pre-specified sensitivity, analysis was done by best worst and worst best imputation approach to assess the effect of missing data. The secondary outcomes were measured on a single occasion, were analyzed by using statistical models with the fixed effects as per the primary outcome model. The ordinal composite ranked outcomes using proportional and the odds logistic regression model. The binary outcomes were analyzed as per the primary outcomes. Count outcomes by Poisson regression model. Time to event outcomes with Cox regression, and graft failure with the competitive risk of death by Fine and the Gray regression. So 800 participants were recruited and would provide 80% of 800 participants would provide 80% power at a 5% two-sided alpha level to show an absolute difference of 10% between the groups for the incidence of DGF, corresponding to the relative risk of 0.76 with 1% loss to follow-up and 4% of non-adherence. So in total, 1,350 patients found their eligibility. Out of them, 494 were excluded. 95 did not meet the eligibility criteria. 90 patients actually had to undergo multiple organ transplants. 344 patients actually excluded from the study due to the logistical issues. So 856 patients were randomized. Out of them, 427 randomized into the balanced crystalloid group and 429 into the saline group. 22 patients did not receive a kidney transplant in the intervention arm, whereas 24 did not receive a kidney transplant in the saline group. So total 404 patients in each group received the kidney transplant. Out of that, 9 patients discontinued the trial from balanced crystalloid group, whereas 10 patients discontinued the trial in the saline group. So 395 patients in the balanced crystalloid group were actually followed up to week 52, and 394 were followed up to week 52 in saline group. Total number of the patients were included in the primary analysis were 404, included those who lost to follow-up, and it was 403 in the saline group. Following few slides will represent the baseline characteristics of the population who were enrolled in the study. So the majority parameters actually were comparable between both the two study arms. The majority patients were males. Ethnicity-wise, whites were maximum population up to 57% in balanced crystalloid group and 61% in the saline group. The Asians were only 10% of the total recruited population. The native kidney disease majority had glomerulonephritis followed by the diabetic nephropathy, which was comparable in both the arms, as well as the comorbidities, which did not differ significantly in both the studied arms. These are the few factors which are actually critical, as they actually are the responsible to give rise are the responsible in giving rise of delayed graft functions. Few of them are the dialysis vintage, peak panel reactive antibodies, the HLA mismatches, and as we can see that both of all these factors did not vary in between these two arms. The basiliximab was the induction agent used in most of the cases, and majority of the patients were on triple immunosuppression, including glucocorticosteroids, tacrolimus, and the mycophenolate mofetil. The expanded criteria donor was again 29% in the balanced crystalloid group and 27% in the saline group, which was comparable. The donor terminal serum creatinine was 0.68 and 0.69 in balanced crystalloid and saline group respectively. So looking at this data, it actually says that the recruitment was the baseline characteristics were comparable between both the studied arms. So from the time of randomization up to 48 hours of post-transplant, balanced crystalloid group received nearly 8.1 liter of a fluid volume, whereas normal saline group received 7.1 liter. And this was actually reflected by the increased urine output in the balanced crystalloid group. Non-trial fluids were given mainly for the reason of the medicine administration, which were given equally. This was mainly 0.9% normal saline, and it was given equally in both the study arms. The use of blood products also did not differ in both the groups. So these charts actually represent the mean chloride, sodium, bicarbonate, and the blood pH values, which were recorded up to day 2 post-transplant. The red indicates the balanced crystalloid group, whereas the blue indicates the balanced crystalloid group, and the red indicates the saline. So as evidently the sodium and the chloride values were more in the normal saline group, whereas the bicarbonate levels and the pH level was more in the balanced crystalloid group. The patients who were in the normal saline group has actually exhibited hyperkalemia as well as the hyperchloremic acidosis. The mean serum potassium concentration, urea, hemoglobin concentration, as well as the body weight up to day 2 in between both the arms did not vary significantly. The urine output in the balanced crystalloid group was up to 6 liters, whereas it was up to 5 liters in normal saline group. This was the cumulative urine output up to day 2. And the second diagram actually represents the serum creatinine trend, which has been followed up to week 52. But the current diagram shows the trend up to week up in the first week, or up to day 7, which does not show any statistically significant difference in both the study arms. So the primary outcome was the delayed graft function, whereas when they use the balanced crystalloid, 30% patients experience delayed graft function, and delayed graft function was 40% in the saline group, which had the relative risk of 0.74%, and it showed the statistical significance. So there was an absolute risk reduction by 10%, which means that for each 10 patients which are recruited in the balanced crystalloid group, one would actually one would benefit by not getting the delayed graft function. This was a subgroup analysis done for the delayed graft function, which showed the variable results, but obviously favoring balanced crystalloid. The results were prominently seen for the donation after the circulatory death, as compared to donation after brain death, as well as when the KDRI tertiles, uh, when the patients had a higher KDRI score, or when they were in the third tertile, the effect of a delayed graft function was much more less than compared to the earlier tertile in the balanced crystalloid group. These are few of the secondary outcomes. The number of dialysis sessions up to day 28 and the duration up to day 48 did not vary between the two study arms. As well as the total number of the dialysis sessions, the saline group required 190 more sessions of the dialysis as compared to the balanced crystalloid group. We are not sure about this hazard ratio showing 1.10 when the duration of the dialysis, numerically, it's 0 between both the balanced crystalloid group and the saline group. This diagram actually is the dotted line in this diagram differentiates between those who required the dialysis and those who did not require the dialysis. As I said, the 190 more treatments were required in the saline group as compared to the balanced crystalloid group. The dialysis duration up to week 12 was analyzed using the Cox proportional hazard model for time to dialysis independence, and the shorter times were considered favorable. Because of this, hazard ratio more than 1 favored the balanced crystalloid group. A few of the other secondary outcomes, including creatinine reduction ratio on day 2, creatinine reduction more than 10% within the 3 days of transplant, the peak potassium in both the groups, as well as the treatment required for the hyperkalemia, fluid overload by day 2, which was defined by more than 5% of the weight gain, did not vary significantly in both the study arms. Acute rejection episodes, number of transplant biopsies up to day 28, graft failure, including deaths up to week 52, graft failure censored for death up to 52 weeks, and graft failure up to 52 weeks with the death as competitive risk did not vary in both the study arms. So this is about the adverse events. There was a statistically significant more ICU admissions requiring ventilation in the saline group as compared to the balanced crystalloid group. So the delayed graft function was statistically less in the balanced crystalloid group, and this was consistent with the other studies, but there was a low evidence regarding the reduction of DGF with the use of balanced crystalloid. Incidence of hyperkalemia was low in our study. Hence, the safety concerns regarding use of potassium-containing crystalloids remain unjustified. As consistent with the other studies, serum chloride concentrations were lower in the balanced crystalloid group, as well as the saline group actually exhibited higher proportions of hyperchloremic acidosis and eventually hyperkalemia. There was no difference in the secondary outcomes. Despite these differences, the length of the stay was similar between the two arms, which might indicate increasing use of outpatient dialysis and clinic follow-up for otherwise stable DGF patients. There was no difference in the graft function from week 12 up to week 52, graft failure or mortality, even though the study was underpowered for it. The reduction in DGF was more prominent in donation after circulatory death than the DBDs when balanced crystalloids were used. As in this registry, the analysis comparing DCD kidney pairs from the same donor who did and did not have a delayed graft function in the recipient. The graft function was similar in both the groups up to 12 months, but by 3 years, the patient who had delayed graft function significantly had a lower graft function and a higher risk for the graft loss, suggesting that the deleterious effect of this delayed graft function might not be evident by the analysis which was restricted to the first year of the transplant, which is what happened in this trial. This actually represents and compares the normal saline, its constituents with the human plasma and the other low chloride crystalloids. Evidently, the sodium is to chloride ratio in the normal saline is 1:1. When in the intervention arm, which was Plasma-Lyte 148, it was 1.43:1. So the major culprit here is the hyperchloremia. The hyperchloremia in the afferent arteriole, which gets reflected into the increased concentration of the chloride into the tubular fluid, which further activates the tubuloglomerular feedback, causes afferent arterial vasoconstriction. There's an increased afferent arterial resistance and the decreased renal blood flow as well as the perfusion, which is why we see more AKI because of the reduced graft perfusion and as well as which is why we see that is what we see in the normal saline group. These are few adverse events which are associated with the normal saline group. It is associated with more incidences of hyperchloremic acidosis. There is more interstitial fluid volume, which leads to the edema. Patient has shown renal vasoconstriction, decreased renal plasma flow, and the drop in the GFR. In the GI system, it was associated with gastrointestinal edema. It has led to ileus and also impaired anastomotic healing. There was increased need for the blood transfusion in the saline groups. The clinical outcomes, there was increased postoperative complications, increased incidence of mortality, increased incidence of AKI, and the need for the renal replacement therapy. These events were seen mainly when the balanced crystalloids were compared with the normal saline in the critically ill patients. The strength of this study was Best Fluids trial was an investigator-initiated double-blind RCT, which provides a robust, high-quality data, and it was a high-quality study design. The selection bias was minimized as it was a registry-based design, and the randomization was done before the transplantation to avoid the contamination due to open-label fluid usage. The blinding was well done with the fluids appearing identical by giving the barcode to the trial fluids. Adherence was good with the negligible missing data for primary outcome. The baseline characteristics were similar in both the participants. The data accuracy and the competencies was guaranteed because the hospital researcher staff as well as the auditions were involved in the data collection and the entry. Whereas the limitations of the data collection was limited to the routinely recorded clinical care. There was the missing data on the few of the laboratory measures except creatinine, as well as some of the hemodynamic variables like blood pressure, residual urine output, drug dosing, therapeutic drug monitoring, and surgical anastomosis time was not taken into consideration. The use of machine perfusion was underutilized during this trial. Thank you.
Thank you, Dr. Vipul, for the wonderful presentation. So before I invite the panelists to start with the discussion, I would like to ask Dr. Jayaprasad Tripathi, Associate Professor in the Department of Community Medicine at AIIMS Nagpur, to explain to us about what a pragmatic study means, which was discussed in this, with some data on the types of blinding in various RCTs. So we'll have this small discussion about this before we proceed with the general discussion.
Okay, thank you. Am I audible? Am I audible now?
Yeah, you're audible and slides are visible.
Okay, thank you. So I have just a few slides on pragmatic RCTs and blinding as I was listening to this nice paper in Lancet. I'll begin with talking about why do we need pragmatic trials. Now, of late, there has been an increase in interest in obtaining evidence in real-world settings. Now, till now, we have been doing RCTs in very strict, tightly controlled settings with very strict inclusion and exclusion criteria. So that is the conventional RCT, and we coin it as explanatory RCTs. On the other end of the spectrum is your pragmatic RCTs, which even by the word pragmatic means more practical and yielding more real-world evidence. Now, as I was listening to the speaker, in his limitations, he said that data was limited to routinely collected data in clinical care. And that is what precisely we mean by pragmatic trials. We do not go for monitoring or we do not go for data that is not collected routinely as we do in routine clinical practice. We may be collecting a lot of other data on patient outcomes or on patient routine monitoring of care in certain very specialized tertiary settings, but routinely whatever we collect, that's what was part of this trial. So that is again one reason why we call this as a pragmatic trial. Now we get real world evidence from a lot of other study designs like observational studies, which are not interventional. And there are non-randomized studies, large cohort studies or registry-based studies where we get real-world evidence. But the drawback with real-world evidence, with such observational data, is they come with their own biases, and especially confounding. We do not have control over which patients receive what type of treatment. So the major drawback in such observational data is confounding. Now that's why we move towards RCT, so that we take care of confounders through randomization and through other techniques. But when we do a conventional explanatory RCT, we limit ourselves to such a smaller group of patients with such stricter criteria of inclusion and exclusion that our results are also more in tune with the group of patients that we cater to. And we cannot generalize our results to other group of patients. Now, pragmatic RCT is somewhere in between RCTs and observational studies, which takes care slightly of both of these things. It provides you real-world evidence, and at the same time, it removes the bias that is there in observational studies due to lack of randomization. I would rather put it in this graph where we always look for trade-off between internal and external validity. Now, internal validity is the confidence that we have in our own study results. So if we say that relative risk is 2.0, and how much confidence do we have in our estimate of 2.0? That is internal validity. External validity is if we say that in my group of patients it is 2.0 relative risk, can I say that in another group of patients the relative risk will also be 2.0? So external validity is generalizing your findings to other group of patients, whether internal validity is the confidence that you have in your own study, okay, the estimate that you get in your own study. Now, RCTs are internally valid, right? So they are very valid in their own set of patients, but the findings from an explanatory RCT, a conventional RCT, may not be applicable to other group of patients. Observational studies, on the other hand, are generalizable. You can generalize the findings to a large pool of patients because the findings have come from a large pool of patients. But internal validity is a question mark in observational studies, mostly primarily due to confounding bias. But pragmatic RCTs combines both of these. It has certain merits of RCTs like randomization, blinding, and follows a particular protocol for RCT. At the same time, it is not having stricter protocols, stricter ways of inclusion and exclusion criteria. So it deals with a large pool of patients, but also has the benefits of an RCT. So that's why we call it a pragmatic randomized control trial. The key features of pragmatic RCTs is pragmatic RCTs attempt to answer the question, does the intervention work in the general pool of population or work in a representative pool of patients or not? So this looks at effectiveness, whereas the conventional explanatory RCTs is mostly dealing with efficacy. It's not dealing with effectiveness, it's dealing with efficacy, where the question is whether this intervention will work in a specific group of patients or not. So generalizability is an issue with conventional RCTs. Pragmatic RCTs use broader eligibility criteria than those for explanatory RCTs. And we have a heterogeneous group of participants in pragmatic RCTs, whereas in conventional RCTs, the group of patients are very homogeneous and follow a very stricter inclusion-exclusion criteria. There is more non-adherence to trial protocol, right, and dropouts as well in pragmatic RCTs because non-adherence and dropouts is basically is part of the real world that happens, right? If you implement this trial in your group of patients, in your clinical practice, you're likely to have non-adherence and dropouts. So we need more sample sizes in pragmatic RCT so that we take care of this non-adherence and dropout and still be able to have adequate study power. Pragmatic RCTs doesn't require very strict monitoring protocols, and it is mostly done along with your routine clinical practice, of course, with little rigor, I'm not saying that it should be done casually, but I'm saying that with less rigor as part of a routine clinical practice, it is carried out. So it also reduces the burden on researchers and participants. Whereas at the other end of the spectrum, we have explanatory RCTs. These are some of the key features of pragmatic RCTs. I would summarize pragmatic RCTs by just saying that it deals more with effectiveness of your intervention and gives you a real world evidence, more externally valid, and at the same time internally valid as well because of the merits of randomization, blinding, and other RCT features. Now, moving on to some very key terminologies in RCT, I'll just quickly, so whenever we say randomization, it comes along with allocation, concealment, and blinding. And it is very important to understand the difference between these three things. And in the next 5 minutes, my objective will be to differentiate between randomization, allocation, concealment, and blinding. So it's written binding, but it's actually blinding. And now randomization is, some people say there are two aspects to randomization. One is generating a random allocation sequence, right? That is the first aspect. Or how do you generate a random allocation sequence? And the next aspect of randomization is how do you conceal that sequence until you assign treatment to all your participants. So you generate a sequence, that's the first aspect of randomization, and then you conceal the sequence so that others do not know what is your sequence until you have assigned the treatment to your participant. So the second part is what we refer to as allocation concealment. That is, we conceal the allocation sequence, conceal the random sequence until you assign which participant is going to which group. So until that moment, you conceal. But after that, it's your choice. After that, it's your choice. You may tell to the participant, okay, you're getting a placebo, you're getting drug A, that is your choice. And that's where you come to blinding. Okay, but till the moment of assignment, it is allocation, it is randomization followed by allocation concealment. Once you have allocated the sequence to the participants, you have given them in which arm he or she is going to be, then it's up to the type of trial that you are conducting, whether you are doing a blinding or not. So this sums up randomization, allocation, concealment, and blinding. So you begin with randomization. The first aspect is generating a random sequence. Then the second aspect is concealing the sequence till you assign participants to your intervention and control group. Then comes blinding. Now, once the participants are in some group, intervention or control group, later, if the patient is still unaware of the treatment he's receiving, he still does not know whether he is in intervention or control arm, then that is called the single blinding. If only patient is unaware of the treatment, rest everyone is aware of which patient is receiving what. So then it is single blinding. But we go one step ahead. If including the patients, if the clinician who is administering the treatment or the procedure or the data collectors who collect data are also unaware of the treatment that the patient is receiving, that comes double blinding. If we go one step ahead, if the data analysts or the one who assesses outcomes or the one who is assessing outcome of the patient, because patient outcome is very important and we do not want anyone to tinker with the outcome data. So if the one who assesses outcome or the one who analyzes the data analysis, if they are not unaware, if they are unaware of the type of treatment the patient is receiving, then it is called triple blinding. I mean to say that when they're analyzing the data, they will only have group A, group B. They will not have crystalloid group and saline group. So they will have group A, group B. So if that stays throughout till they have analyzed the data, that is your triple blinding. And by doing these, we avoid certain biases. Now, if we do randomization and allocation concealment, we minimize selection bias and confounding bias, because by randomization and this allocation concealment, by randomization, we expect that the confounders are equally distributed in both the arms, in the intervention and the control arms. And by that, we try to handle confounding. And by allocation concealment, if we do not know which patient is receiving what at the time of allocating treatment, we cannot choose participants to be in intervention and control arm. It is completely done by the random sequence. And as an investigator, we have zero role in that. So that minimizes your selection bias. And of course, blinding, blinding reduces attrition among patients, because if a patient knows that he is in placebo arm, we are likely to lose him. But if a patient is not knowing whether he is in intervention or control arm, we may have that patient till the end of the trial. And it also reduces measurement bias. If the outcome assessor is not knowing if the patient is in control or intervention arm, there is minimal bias in his outcome assessment procedure. There are different methods how allocation is concealed. Firstly, the person who generates the sequence should not be the person who allocates the treatment. So somebody else must be generating a sequence and somebody else must be allocating the treatment. There are many centralized randomization systems now available. The traditional one is still the serially numbered opaque sealed envelopes, which is still the traditional way of concealing allocation sequence. I'll end my presentation here. I'm open to any questions or queries, either now or maybe at the end of the session. I'll leave it to the organizers.
Thank you, Dr. Jayaprasad. We'll be taking questions as and when they come up in the chat box. Now I invite Dr. Shishir Gang sir and Dr. Tukaram sir to initiate the discussion for the JC.
Thank you, Dr. Arun, and also like to thank Vipul and Jai for providing an excellent overview of the study, and followed by Dr. Jai for providing an exhaustive understanding of what this trial or what are the statistical methods or the trial plan is. So this, we all agree there is an important question that whether to use saline or to use a balanced fluid. Unfortunately, the balanced fluid which they have used is not widely used or available in our country. It's expensive, though it's available. And mostly we use ringer lactate. So the first question or discussion point, which I would want my colleague Tukaram also to pitch in, is generally it was assumed in this trial that everybody was used normal saline 0.9% right from the patient going to the theater till 48 hours. As we all understand that the normal fluid strategies that we normally follow is to initially use saline, and then maybe or use ringer lactate or whatever. And when the patient comes out, if there is a good amount of output, we can use what is known as half normal saline or some combination of things, because usually it is thought the urine output is about half normal saline, and we try to chase it with that. So that is one difference that we normally find in the practice that we do here, and what possibly they assumed that they were doing there. And I would want Tukaram if he has also some thoughts on the initial.
There was another question here in the box. Why is there any study about RL comparing similarly with versus normal cell? Probably there is no much interest in the RL because RL, especially from the industry standpoint, there is no much interest in examining RL vis-a-vis normal saline, because if we see all the trials of normal saline versus balanced crystalloids, RL doesn't figure any place. And I don't think there is a valid medical reason for that to be the case, because except for little hypotonicity, there should not be any much difference, except so there was a issue with patients with traumatic brain injury where hypoosmolality of this fluid might be a concern, that there may be a cerebral edema that may get aggravated. But outside that circumstance, there is no reason why RL should not be. So that was one question that was quite repetitive, why RL is not figuring out in any of the studies. And I agree with Dr. Gang. Initial strategy is usually the normal saline, and that's what the current strategy is. But now, all the purpose of this exercise, Dr. Vipul, you had excellently put together everything. It's to understand from here onwards whether we should be changing our practice. So that is a very, very important question that you should be answering for yourself and for others when you are analyzing an article. And what is your take? What are the concerns that you have for immediate applicability of this particular trial, or you have no objection and you should right away switch? Had it not been the cost, because cost, let us forget that for the purpose of scientific discussion. Even if we forget the cost, whether it is a time to completely switch, and that for that probably I have some reservations. Now, Dr. Arun Kumar had elegantly discussed the pragmatic RCTs and advantages, but then they also will have some problems of their own, especially because the data on each and every aspects. And here, if you go to the statistical methods of this article, you will find that they are not the routine statistical method that we typically see in a randomized controlled trial. Because in a randomized controlled trial, we expect the characteristic to be balanced, and we don't have to adjust for a lot of things which might itself affect the outcome other than the intervention. But here, because DGF is such an outcome which will not be affected by fluid alone, there will be a number of factors. For example, somebody might develop hypotension during anesthesia, somebody might have a surgical difficulty, some patient might have some or other reason. So those issues are very pressing, and to address that, authors have done lots of regression techniques, and they will be a topic of discussion in itself, but they had done lots of regression techniques which ordinarily a randomized controlled trial won't employ. And Vipul, have you gone to the initial protocol of the trial? Initial outcome, primary outcome of the trial was not DGF.
Yes,
It
it was
was
actually the composite outcome of which was actually included as a secondary outcome in the final analysis.
correct. So what happened was, initially when trial protocol was published, the outcome specified as a primary outcome was a rank composite outcome of duration of DGF and creatinine reduction ratio, day 2. That is creatinine day 1 minus creatinine day 2 divided by creatinine day 1 into 100. So the CRR2 plus number of duration of DGF was the composite outcome. But eventually they realized that they sent the protocol for peer review, and they realized that DGF will be more robust outcome than this, because pragmatic trial should have some outcome that is immediately important to the patient and to the physicians, and that's why they thought of changing it back to. But then surprisingly, this particular outcome has not remained any different in the two groups. Whether it is a duration of DGF or creatinine reduction ratio that they had hypothesized as initial. So that is another puzzling aspect of their results. Why it didn't figure out in the secondary outcome if there was a difference in the dialysis? Why not creatinine decrease slowly? Why not duration of DGF different between the two groups? So that is another concern I have about this. Another thing you also had pointed out, the last parameter in the last table of this article. The ICU admissions were significantly more in saline group. So that is something that is interesting and again puzzling. Why should not many people required to go into the ICU? And if we imagine a healthy dialysis patient going into ICU, immediately that what comes to my mind is probably a fluid overload or a situation like that, for which patient might have some respiratory distress or something like that. So that might have, because if patient died, they had included it as a DGF, so that they had collated to the outcome of DGF. And if you calculate what is called as fragility index of a trial, that is number of events that would require to reverse the result of the trial. If suppose these many events occur more in the other group, then trial results will be opposite. That is 13 for this trial. That is a good. Actually, some trial have it 4 or 5 or 6. But if you consider those admissions, there are 12 or 13 in saline and only 1 in RL. So that is something other. So I think I will stop here. You can take it from here, sir.
Thank you, Tukaram. I think that's what we need to really ask the question, that what happens in our practice. And he has alluded to some of the important points. The second point, which I thought, was the use of the induction agent, because in Australia and New Zealand, the predominant induction agent used is Simulect. And in our country, especially in deceased donor transplant, we use antithymocyte globulin. And as you all understand, there's numerous data to show that antithymocyte globulin, when used, is associated with reduced delayed graft function. So whether that would also have an implication in the practice that we have. Having said that, of course, it does make sense that at least in a randomized trial in their group, they did show an advantage. So this would be another point at some point discussion in that. The third point, which I thought was that despite the numerically increased delayed graft function, the other outcomes which are associated with delayed graft function like rejections, and you mentioned about the 1 year graft survival not being different, and it would take 3 years to show some difference. But the rejection rate, which we normally think with such a large trial, would have been larger in the group with a delayed graft function. But at least in this trial, it did not really come out to be that. And the number of course, the events were low, but still one would have expected numerically to be more. So these are some of the things that when you do a trial, you find that things just don't really match what we always thought. And that's, I thought, just brought an attention to that. If there are any questions, we can take them from the chat box.
I think
Participants, do they have any?
There was one question from Professor Agarwal, sir. Why can't we have all pragmatic RCTs? It answers a lot of questions. It is easier to do. Why not all have pragmatic RCTs?
Yeah, so
this is for this is for our Dr. Jay Tripathi. If you could, from the statistical point of view.
Yeah, okay. I think that's a good question. And so as a group, I think most of us, we are moving towards pragmatic RCTs, not just in the field of nephrology. I think in public health, in cardiology, cardiovascular research, and there's more stress on pragmatic RCTs than on conventional RCTs. But having said that, I think drug trials are something which is specific drug trials are something which is still very much done in strict conventional RCT mode, especially when it's something a new drug which is before it has not come to the market. It has been, the molecule is new, and it has to be done in very strict control settings, because whatever information we have is maybe limited to a particular group of patients, and we are not sure how much and how that will affect other group of patients. In that case, I think very novel drugs, very novel strategies generally begin with a small group of strictly controlled settings like conventional RCT. And once we have some confidence in those estimates, we certainly have to move towards pragmatic RCTs. That's my take on pragmatic RCTs versus conventional RCTs.
So I would just add a word about pragmatic versus explanatory RCTs here. Now, putting pragmatic RCT, as already highlighted, they are very, very useful because they can be completed in short time with minimum cost. They are more aligned with real world settings, and there are such advantages, obvious advantages. But then whether explanatory or pragmatic, so if and how an intervention works, whether intervention works and how it works. So to understand that, one needs an explanatory RCT. And once we have understood that, how well it works in real life will be a job of a pragmatic trial. So if you go to the fluid trials, balanced crystalloid versus saline in non-transplant settings, otherwise, other way it has happened. Like initially those SALT ED and SMART and SPLIT trials, you have shown a very good visual abstract in the initial slides. Those were pragmatic RCTs. They were massively large and phenomenal recruitment rates. Thousands of patients were recruited over months, and they came out with the result. But those results were refuted by two explanatory, very well conducted explanatory RCT, that is basic and classic. So this is something that we should always keep in mind, that explanatory RCT, to answer whether if and how an intervention works, they are more important to understand this question, whether intervention works and how it works. Once we have that idea, then we go to see whether it, in real world setting, out of trial for all patients, it is similarly working or not. So that probably also is required in now transplant setting. So a well-conducted explanatory RCT probably, I feel, still is required to reliably say goodbye to saline in transplant resuscitation.
Dr. Sanjay would like to ask a question.
No, I would like to ask that if you compare conventional RCT with a analysis of intention to treat analysis versus a pragmatic, then why not conventional with intention to treat analysis with also will be a real world situation versus pragmatic, and that will be giving more weightage in terms of a efficacy and also balance the real life situation. What is your comment between two?
I think with this analytic strategy, yes, you are moving one step towards a real world evidence setting. But I agree. But when we do a conventional RCT, our objective is, as pointed out, objective is to see how the intervention works, and we would really like to have a protocol in place, and we would like to see patients adhering to the protocols and then finding out the efficacy of the intervention. And then the purpose that we began with a conventional RCT is to look at efficacy of that intervention in a particular setting. But what happens when there is non-adherence, there is loss to follow-up, and there is crossover from one arm to the other. And that is how in real world happens. And there are analysis, as pointed out, there are analytic strategies to handle that through intention to treat and per protocol. And that is again one step towards real world evidence. But there are again some flaws in those analytic strategies which renders it not as good as a pragmatic RCT. Because the setting in which the patients, the group of patients that you have is completely different from the group of patients that you would have in a pragmatic RCT. Right? The pragmatic RCT will have a heterogeneous group of patients. A conventional RCT will have a very homogeneous group of patients with very strict criteria for inclusion and exclusion. So again, with a different group of patients, generalizing the findings of one RCT, conventional RCT, to an RCT which is done with a heterogeneous group of patients, there are some reservations in generalizing the findings. So,
I have one or two more points.
Yes.
Is the pragmatic RCT is difficult to interpret in a clinical situation where there are potential of multiple confounder like transplant, as in this case. So where the data is not fully available of the multiple confounder, then the pragmatic trial conclusion might lead to a situation where we are not sure whether we should change the practice or not, like in this trial.
Okay, I got your point. So the purpose of pragmatic RCT is, again, we don't intend to lose the benefits that we get in a conventional RCT. In a conventional RCT, we still go for randomization, allocation, concealment, blinding. Those are the key features of a conventional RCT. And we keep those key features still going in a pragmatic RCT. We still have randomization, we still have blinding, we still have allocation, concealment. So the issue of having more confounders, these features address a lot of that, right? Randomization, allocation, concealment, and blinding address a lot of biases, especially around confounders. Now, even despite doing all these things, we still have some more confounders which we cannot deal with just by randomization or blinding or allocation concealment. That has been, in this paper, that has been taken care of by two more strategies. One is by doing a minimization algorithm while randomization. Now, even if you do a simple randomization or a block randomization, you still can have some differences in confounders. You still can have a intervention group and the control group, which are different with respect to some confounders. To manage that, they have done a minimization algorithm where that algorithm tries to reduce this imbalance in these confounders. That is one. The other way of handling some confounders, even after doing randomization and all the allocation, concealment, and all, is to statistically adjust for those confounders during analysis, which they have also done in various regression models. So these are the two things that you can still do with your data if you have data on confounders, even after randomization and blinding. And then that is the case with any RCT or with any study design, I would say.
Last question. Is this so that every clinical question during the trial can be answered by pragmatic trial, or there are certain situations where pragmatic trial is not possible and you have to go for a conventional RCT?
I would rather say the other way around. I think there might be certain situations where a conventional trial is not ethical, but a pragmatic trial is unethical. I don't see a situation like that, but certainly there are situations where a conventional trial may be unethical, but a pragmatic trial is ethical in those situations.
Okay, thank you. Thank you very much.
Thank
So
you.
I had one question. While I was reading this paper and I was preparing for this presentation, one thing which also struck to my mind that why, as Tukaram Jamade sir said, that why we don't implement this change in our practice when so many RCTs have shown this benefit of balanced crystalloids over saline. Leaving out the cost and the availability issues about Plasma-Lite 140A. My question was, when we have definite evidences favoring these balanced crystalloids, now clearly we don't use ATG as an induction agent in most of our disease donor transplants, or also the Asians in this study were only 10%. But when this is not inferior, why can't we change our practice to balanced crystalloids over saline? Especially when it's non-inferior, then if not generalizable, the data is not generalizable to Asian population, why not balanced crystalloids and why normal saline?
If I may answer, there are several steps to it. One is that there has agreed that there's a lot of data, both theoretical as well as in the literature, about the hazards of using normal saline, especially large volume of it. But if you come into the practice, we have had discussion with our anesthetist, and they were initially worried about the small amount of potassium which is there in the ringer lactate, which we told them is not of a worry, and there are enough data to show that one could safely use that even in renal failure. So there are steps to implementing these strategies in the hospital. So in our transplant program, after a lot of discussion, because morning they always look at the potassium and they don't want to start off with a ringer lactate pumping in when the patient is still anuric. So that's one step within the anesthetics we have to really discuss with them to get that going, one. And as I said, after the transplant is done and the urine output is there, especially, then the pathway is not necessarily only one type of fluid. We often use a combination of ringer lactate, half saline, and even sometimes 5%, because to make it about a half saline type of osmolality, because that's what the urine osmolality is. And sometimes we're passing large volume of urine, then we might want to also look for calcium and magnesium supplementations, especially if there's a large volume. So in a trial setting, it is not very it is difficult to do, because otherwise a lot of confounding would happen. But generally in the practical, we could do. So there is now movement towards using ringer lactate. As Tukaram has said rightly, that because of many reasons, nobody wants to do trials with ringer lactate, but there are trials in non-transplant situation where it has been shown to be equally good or equally safe. Only little concern was that the lactate always requires only liver to metabolize, whereas the acetate, which is there in the Plasma-Lite, can be metabolized by the non-liver things also, and therefore it is not as much dependent on the liver. So if there's no liver dysfunction, of course, lactate is no real problem, and the volume that you give can be easily managed by the liver, so it will not be a problem. Only concern or sometimes might be confounding, because when you're using an ABG and lactatemia may be seen on it, so that you need to understand that when you're using ringer lactate, that might happen. So these are some of the things which really go to it. Another only thing that came to my mind, whether that would have any thing, and I would want others to also understand, that they use gluconate in it. And gluconate, as you understand, is actually does not really metabolize much, but it is excreted freely by the kidneys. And whether that would like to act as an osmotic agent, and that led to more urine output in the group where they had the Plasma-Lite compared to the normal saline group. or whether truly the normal saline of the chlorides really caused the ischemia to the cortex and the amount of output was lower. I'm not very sure, but this may be another point of discussion as to what led to increased urine output. If somebody has thoughts on that, I'm happy to listen on that. Tukaram, you want to say something on it, or anybody else wants to?
I'm not sure, sir, how we are going to measure whether that is going to cause with the renal acidosis because of using normal saline would have caused a delayed graft function or would have caused some amount of acute tubular necrosis. Probably, I mean, if I may say, I mean, usually the biomarkers also would not help because when you're doing with a disease transplant,
Right.
so that will also not help us. Not sure how they would have measured it, whether the acidosis is itself causing the delayed graft function. But one thing, what I could say with your anesthetist being fearful of RL with the potassium, probably what you could explain is normal saline causes more metabolic acidosis,
Right.
and that may cause more hyperkalemia than your ringer lactate. Probably that would convince them to use. Yes.
Yeah, that's an important point that even with normal saline, you get more hyperkalemia. But surprisingly, in this trial, the indication for dialysis for acidosis was not significant.
Yeah.
They listed indications for dialysis. Acidosis did not really come up on the top.
No.
So maybe there are many factors to it apart from acidosis, which this does. And I think we all understand that the history of normal saline has been quite unphysiological to begin with. And I think it's time to abandon that fluid in favor of other fluids.
Thank you all. I think we have reached the very fruitful discussion. Thank you, Dr. Shishir. Thank you, Dr. Tukaram. Thank you, Dr. Tripathi. And most importantly, Dr. Vipul for a very lucid presentation. And thank you for taking up the challenge to present in the large forum. If anyone has any last queries to be answered, they can post it. We could reply them individually, or else we will be closing the session. Thank you all. Thank you all for joining in today.
Thank Darshan and Arun and ISM for getting us all together
Thank you.
and giving us an opportunity.